So another essential partner for CFAR certainly is the Global Health Institute. In fact, historically, the centerpiece of a lot of the global health work done at Duke was in the field of HIV also, though certainly the agenda has broadened quite a bit in the last couple of years. So today's second speaker is Sara LeGrand. Sara joined the faculty in 2010. She got her Ph.D. from University of North Carolina in Health Services Research, and she's a research assistant professor in the Global Health Institute. She's going to tell us today about her work on the intersection of substance abuse, mental health, and HIV prevention and care.
Good afternoon. So this afternoon, I would like to tell you a little bit about my research and my use of two very different approaches to address substance use, mental health, and HIV prevention and care, networks of care and social networking. So just a little bit of background. Substance abuse disorders are highly prevalent among individuals living with HIV, and substance abuse disorders are consistently associated with poor health outcomes. Often substance abuse remains untreated among individuals living with HIV. Therefore, effective and innovative strategies for reducing substance abuse are needed. Similarly, there's a high prevalence of mental health disorders among individuals living with HIV. So these are also associated with negative outcomes and often remain untreated. So the first approach I'd like to talk with you about is networks of care. And so with this approach, we actually use a very intensive substance abuse and mental health treatment intervention that's combined with or is supplemented by a network of care, which includes medical providers, behavioral health providers, and case managers. And so before I tell you about my own research on networks of care, I'd like to share with you the history of this research at the Center for Health Policy and Inequalities Research, which is within the Duke Global Health Institute. So back in 1998, Dr. Catherine Wetton was funded for the first study on integration of substance abuse, mental health, and HIV, which was funded by the NIH, SAMHSA, and HRSA. And since then, there have been multiple studies that have also looked at integration of care. And so I'm going to give you a little bit of information on these studies before coming back to my own research. So all of these studies are based on the same treatment model. So this model was developed in the first study, and is based on the biopsychosocial treatment model, which is based on stages of change and cognitive behavioral theory. So it includes 12 months of intensive substance abuse treatment, which includes individual and group sessions, and some level of mental health services. And so where these studies differ is where they fall on the integration continuum. And so at the first phase of the integration continuum, you have coordinated care. And so that involves communication between behavioral health providers and medical providers. So they may be at different locations. So the second is co-located care. And so that's when behavioral health services are provided in the medical setting, so in ID clinics in this case. And then integrated care takes it a step further, where behavioral and medical treatment plans are in the same plan. So as you can imagine, with the co-located care, that obviously has major benefits for both clients or patients and providers. So for patients, there's a decreased burden of time. There are not as many transportation issues to deal with. And for providers, there's an easier referral system in place, and there's also more opportunities for formal and informal communication. And so integrated care just takes that even a step further. So back to the studies that I mentioned before. So our first study was one that involved coordinated care. So there was regular communication between behavioral health providers and medical providers, but the treatment itself was actually provided outside of the ID clinics. In the second study, the services were co-located. So the behavioral health care, the treatment services were provided within the clinics. And there was also more multidisciplinary informal case conferencing as a result. With the third study, it was also co-located with more elements of integrated care. So again, the multidisciplinary frequent informal case conferencing, even more, and also shared electronic medical records. And so some of the results of the study, so the first study was a randomized controlled trial. So there was a control group. There were many outcomes measured in the study. And there were phenomenal results, really. So those receiving the intervention experienced greater decreases in substance use, psychiatric symptoms, hospitalizations, and ER usage. And those receiving the intervention also were more likely to receive antiretroviral medications and psychotropic medication regimens at follow-up. So the second study was an effectiveness study. So it used a pre-post-post design, and there was no control group. So in this case, we also saw decreases in alcohol and drug use, addiction severity index scores. And interestingly, there were changes across, there were no differences in changes across site. So this was conducted at 3 different ID clinics, and which brought together folks from different areas. So we have rural patients, we have patients living in rural areas, suburban areas, and rural areas. So there were also no differences by gender, race, and income. So this is basically working for a wide variety of patients. And so at this point, we realized that, you know, we have something that works across clinics, it works across different types of patients. So this was some indication that this is a study worth, or a treatment model worth disseminating. So the third study was also an effectiveness study, pre-post-post design. We also saw positive changes in alcohol and drug use severity scores. So I guess in conclusion, what we found is that these different studies were highly effective in improving outcomes in terms of substance abuse, and also from the RCT, we could see that it also had positive outcomes related to HIV care. So now I'm going to take a brief detour from the networks of care approach, because I wanted to let you know how I got into the research related to networks of care. So from 2009 to 2011, I worked with Dr. Susan Reef on her collaborative HIV/AIDS mental health project. And so this study was conducted in Charlotte, North Carolina. And just to back up a second, the studies that I discussed before were all based in the Triangle. And so in Charlotte, it's a very different system there of medical care, or HIV care. Services are very fragmented. It's a difficult system to navigate. And there's limited availability of substance abuse and mental health treatment. So this study, we developed a in-home mental health treatment program and examined the feasibility and outcomes associated with this program. I'm not going to talk too much about this because it's really just to get back to how I came to work in networks of care. But we did see significant improvements in mental health outcomes, also increases in adaptive coping, and improved social support. However, what we found is that those who had substance abuse disorders were not achieving the same outcomes. And so what we set out to do was to determine what the barriers were for people receiving substance abuse treatment, and also determine if we could, or to develop an intervention or an intervention framework to address substance use in this area. And in particular, we were hoping to develop an intervention that worked in this context, where we know the services are fragmented and that substance abuse treatment was not readily available. So this was a CFAR-supported study. Thank you, CFAR. So we conducted 2 focus groups and 20 interviews with HIV-positive individuals with a history of substance abuse, and we also conducted 2 focus groups and 17 interviews with providers, HIV providers, and substance abuse and mental health providers. And so what we found from our participants was that HIV-related stigma, social isolation, lack of motivation for change, and lack of knowledge about substance abuse care resources were the major barriers for receiving substance abuse treatment. What we heard loud and clear was that the participants strongly and consistently recommended the use of HIV-positive peers to address substance use issues. And so based on those findings, and with a task force and a community advisory board, we developed the HSAC, for lack of a better word, term, peer navigator intervention. And so this was a standardized peer navigation services, which include outreach by a peer, manualized education and skills building for navigating the complex system, motivational enhancement provided by the peers, and also helping link folks to substance abuse services. Another key piece is that the peers were available to provide support, which was expressed as a really high need among those who participated in the focus groups. So the peer navigator is also paired with a case coordinator who facilitates the initial substance abuse assessment and assists with any complex needs. And so now we come back full circle to the networks of care approach. And so we took the findings from HSAC and also the intervention that was developed and designed a study that builds on the treatment model from the prior studies. And so in the Carolina Alcohol and Drug Resources Project, which is funded by SAMHSA, we incorporated that model, thereby incorporating a peer navigator and a case coordinator into the network of care. And we also expanded services to Charlotte, which is huge. So we know that we heard that peer navigation services would be very helpful in Charlotte, and so now we have the opportunity to provide those services along with this, on top of this treatment model that we already know has shown signs of effectiveness. We also added HIV testing and substance abuse treatment for high-risk HIV-negative Black MSM. So now you have the full picture of all of the studies that have been conducted by the Center for Health Policy and Inequalities Research and the ongoing research. So my font's different than I thought it would be. Anyway, so the next approach I want to talk with you about is radically different. So this approach involves a internet and mobile phone-based intervention that's a whole health intervention that's designed to indirectly influence substance use and mental health, and also to reduce social isolation, improve social support, and build a sense of community. Social isolation, social support, these are all factors that we know are related to mental health and substance use. And these issues are particularly important among individuals who are highly marginalized. So one such marginalized population is young Black men who have sex with men. And young Black MSM continue to experience significant increases in HIV incidence and AIDS diagnoses, and are at particularly high risk for substance abuse and mental health issues due to homophobia, racism, HIV stigma, lack of social support, and social isolation. So the question here was, how do we reduce social isolation, build a sense of community, and create positive norms to improve HIV, substance abuse, and mental health outcomes? So in this particular approach, we're actually capitalizing on the high use of social networking, mobile phones, apps, all of those, to provide a tailored and customized, engaging health promotion intervention. So healthempowerment.org was created by Dr. Lisa Haito-Weidman at UNC. It's an interactive, mobile phone optimized online intervention that aims to reduce risky sexual behaviors, promote health and wellness, and provide a platform for community building. So Health Empowerment was originally developed by Dr. Haito-Weidman as part of a K43 award, and so she developed the intervention and then conducted a pilot RCT. And then she was awarded an R01 to enhance the intervention and then use it in a larger RCT. So before I get into the specific features that within the intervention that address substance use and mental health, and also the social networking features, I want to just kind of give you an overview of the homepage and some of the features included. So Health Empowerment is it uses a responsive web design, so it can be viewed optimally on any device. And so you can see here on the left is what the homepage looks like on a laptop or on a computer. And on the right, you can see what the homepage looks like on a mobile device. And so it's responsive to any size device. So a few other things I'd like to highlight. The profile here is a customizable profile. This is actually my, doesn't really look like me, but it actually can show also some of the profile things like your sign and, you know, what are three ways you would describe yourself. And the avatar is customizable, so it gives people a visual representation of themselves on the site. The news feed shows all of the current activity on the site. So when people post, post comments, reply, like somebody's post, it all is shown in the news feed. The new stuff section basically just highlights new features of the site. So one other pretty important feature of health empowerment is that users earn points for activities on the site, and so they use the points to improve their status or to level up, and they can also use points to buy swag from the HMP store. And so now I'm going to just give a brief overview of some of the features that do more directly address substance use and mental health. So the first section, so this is a screenshot of the page with, well, let me use the pointer, that'll help. Okay, so the Empower Yourself section includes articles and videos to improve knowledge on a variety of health and wellness topics. And so here I've chosen the Empower Yourself menu and selected health and wellness and gone over to mental and emotional health. You can see all the different topics that where articles and videos are included. You can also see in the Empower Yourself section that there's a section on drugs and alcohol. So Empower Yourself is really designed to improve knowledge on these topics. So the Tools for Health section, I wish I could really had time to go through more of these, but it would just get entirely too long. So the Tools for Health section includes a lot of different approaches for improving health. So the goal setting section, users can basically set goals around any kind of topic they want to related to health. So they could choose to reduce substance use over the next week. So the scene includes interactive decisional balance activities. So it's kind of like a choose your own adventure, and you make choices, and some of those use of substances or some of the decisions have to be made around whether or not to use substances. So the Judge Your Skills section includes quizzes and on a variety of different topics, including drugs and alcohol, and there are multiple levels of quizzes, and so when a user completes one level of the quiz, it unlocks the next level. Oh, and finally, almost missed it, the Know Your Risk section actually includes screeners, and so there's an alcohol use screener, and so a person completes the screener and then gets a score, and if there's risk there, then they're actually given resources for addressing the issue. So the Testing and Care Resources section, this was actually updated quite a bit from the pilot RCT. This used to be a condom locator, but I think we've since found that people know where to get condoms. That's really not as useful. And so we've actually created a link to the site actually includes the age.gov service locator widget. And so now, what I've done here is basically searched from our zip code, and you can see that there are resources, care, testing, as well as mental health and substance use. And so all of the features that I just went through were included in the original pilot RCT. It's been enhanced and updated, but they were all included in that original RCT. And so what we found was that HMP was feasible and highly acceptable during the pilot RCT. However, in post-pilot interviews and subsequent focus groups, what we heard from the participants is they really wanted to see social networking. They really wanted to engage with others to gather information and to get support. So, again, to connect with others and also health professionals for information. They wanted to be able to be more engaged, create posts, leave comments, and like other posts. And critically important, I think, is to give and receive social support or peer support. So now to talk a little bit about the social networking features that have been added since that time. So the Getting Real section here under the Community section is a place where users can submit stories, art via video, audio, pictures, prose, and once they post these works of art, then other users can comment, like, and post feedback. And so you can see in the predefined areas, the areas that are already included, you don't specifically see mental health or substance use, although if a user decided to post something on this topic, it's certainly possible. But coming out, disclosure, in my community, those are all things that are very much related to mental health and substance use. So the forum is a discussion board that provides users with the ability to post messages on predefined topics that you see here, and also, again, like content posted by others. And so in response to the request for an opportunity to interact with a medical provider or health providers, the Ask Dr. W section is a place where users can post questions for Dr. W about a variety of health topics and receive a response in 72 hours. So you can see here already there's a mental and emotional health section, a disclosure section, which is again very much related to mental health. And again, if users wanted to post other topics that are related, it's possible. And so after the social networking features had been added to the site, we conducted a small 4-week field trial with 15 young Black MSM. The users were asked to log in at least once a week for about an hour per week. And we conducted pre and post surveys and post-intervention interviews. And we also used a pretty complex website utilization tracking. So what we found is that the forum was the most popular feature. So one of the social networking features that was added was the most popular. Topics included testing, HIV medications, but also dealing with depression. So even in this very short 1-month-long field trial, there were already posts to the forum about dealing with depression. One of the other top, in the top 3 at least, in terms of popularity was the Dr. W section. And one of the questions that was posed during that time was also about dealing with depression. So there are the other, just in case you just have to know, the third most popular feature in the pilot or the field trial was the quizzes section. So among many reported changes in the post-intervention interviews, included increased awareness about triggers of risk behaviors, including drugs, alcohol, depression, and lack of social outlets. Again, it's a very small sample size, but there were improvements in social support and a reduction in depression. So what's exciting about the upcoming RCT, which will actually begin probably within the month, is that with a much larger sample size, we'll actually be able to examine associations between engagement with specific areas of the site and outcomes of interest. So again, getting back to this really complex tracking system, we can actually see if participation or engagement with this area is associated with changes in certain health outcomes. So my conclusions is that there's no one-size-fits-all solution for addressing substance abuse and mental health and HIV care and prevention interventions. And interventions just have to be developed to meet the needs of the targeted population. So for some with complex substance abuse and mental health disorders, evidence-based, resource-intensive, in-person treatment may be the most effective. So for some populations, these tried and true, really intensive interventions that we know work may be the best approach. For others who may be at high risk for substance abuse and mental health disorders, maybe less intensive interventions are needed. And in some cases, for some populations, the use of digital health interventions may help reduce some of these risks. And so just a little bit about what's next. The Health Empowerment RCT, as I mentioned, will be beginning soon. I'm also working with our research team to develop a mobile app for Black MSM using gaming and social networking features to improve HIV medication adherence. So we received a Small Business Innovations research grant to do this. And while it is focused on medication adherence, it also includes those social networking features that can help influence mental health and substance use outcomes. And also there's some discussion about maybe modifying health empowerment for use with other populations. So that's all. Any questions? Thank you.
Sarah, how much movement have you seen from your evidence-based results into implementing in broader populations?
Good question.
So could you repeat that one more time?
So you've had some very positive
Right.
results, whether it's the intensive management or creating some of the tools to help social networking. But how much have you seen movement from your randomized trials to implementing in broader populations?
Into policy and services.
Right. So that's an interesting question. So I think for us, we have been able to use the same model to affect outcomes among our, group here in the Triangle and now expanded to Charlotte. But given the nature of the funding for those particular grants, it's fairly limited in scope. I do think that it would be very worthwhile endeavor to reach populations outside of the Triangle with those interventions. It is one thing that, in terms of these lower intensity, maybe a high investment initially, but these internet-based digital health interventions are a lot more scalable. So I actually think that probably it has more likelihood of being disseminated to more populations. All right, thank you.